It's Monday the 7th of March 2016. I'm Russ McLean, Chair of the Patient Voices Group, and today I'm talking with the Chief Executive of East Lancashire Hospitals Trust, Mr. Kevin McGee. For the purposes of our recording, what you're about to hear is unedited and unscripted, and Mr. McGee has no previous knowledge of the questions that I'm about to put to him. The Patient Voices Group works very closely with the Trust on behalf of the patients it represents, but we cannot take on board individual complaints against the Trust. There are procedures for doing just that. What we can and continue to do is to have conversations with the Trust and its board about issues which might affect patients and staff generally. Junior doctors are on the verge of their third spell of industrial action, with a string of sustained strikes planned. Medics have already withdrawn all but emergency action for two 24-hour periods on Tuesday the 12th of January and Wednesday the 10th of February. The British Medical Association had also threatened 4 walkouts, but cancelled these whilst talks were ongoing with the government. Now those talks are off, but the 3 new round of strikes lasting a total of 6 days are planned. In each case, junior doctors will withdraw all but emergency care for 48 hours, resulting in thousands of operations being cancelled. So far, each 24-hour period of strike action has meant around 3,000 operations cancelled nationally, along with thousands more outpatients appointments. The new strikes will take place on Wednesday the 9th of March, Wednesday the 6th of April, and Tuesday the 26th of April. My first question, obviously, Mr. McGee, is going to be how are the strikes going to impact upon you as a trust? And isn't this going to mean more misery, cancelled appointments and operations for your patients?
So clearly this is something we've been planning for now for a number of weeks. What we try and do is keep the disruption to patients to a minimum. So we plan well in advance. We stand down all training and all admin time for senior staff, and we have more senior staff in the wards and departments. But we do have to stand down some routine work, be it some routine operations and some routine outpatient appointments, and for that we can only apologise. We have, over the previous strikes, kept it to a minimum, and we would look to do so over the next strikes. But remember, this next phase is for 48 hours, and the previous strikes have only been for 24 hours. So we're going to have to manage this in a different way, and it will put more stress and strain into the hospital.
Isn't that, we've talked about how the strikes impact on not just the junior doctors, but on the staff that have to work and cover the shifts and things. Surely that does have a big impact on morale.
It's almost like, I suppose, the Dunkirk spirit, really, that, we recognise the great work that the junior doctors do, and there's a lot of sort of moral support for the junior doctors, but the rest of the staff, when they're not here and they are on strike, they really pull together and everybody helps and supports. So we have a system called Helping Hands, whereby administration staff down tools in terms of the day-to-day admin work and go on the wards and departments and health clinical staff. So I think one of the things we should be really proud of in East Lancashire is the way everybody does pull together. So I can't say it won't put more strain in the system. Clearly it will. However, we will cope and we will manage.
Is there a certain number? Obviously, I'm not expecting you to recall the figure off the top of your head, but have you got projections about the numbers of patients who will be affected because of this?
Over previous strikes, it's been very limited in terms of the actual number of operations that we've cancelled. It's been 10, 15 as a maximum. We don't know yet, because we're planning and we're working this through, and we're planning it on a day-by-day basis. We would hope to keep the disruption again to a minimum.
How are you managing that in terms of contacting patients? So obviously we're here, it's the 7th of March. We've got a strike planned for Wednesday. There are further strikes planned during April. Are you already contacting patients who have appointments or due operations on those days?
Yes, we've already contacted most of the patients. So we use various forms. We use written correspondence, but we also use telephones, we use text messages where people have said we can contact them by text. So we try and use every method available. But we try and keep it to a minimum, so we keep it flexible and we keep it right up to the very morning to see how much work we actually need to cancel. And if we can try and get the activity through, we can try and see people, we will do so.
I want to talk now about your A&D or ED, your emergency department. We've enjoyed quite a mild winter so far, and yet your emergency department seems to be really struggling, as do many others. Why is this, and why are you missing your targets and occasionally having to divert ambulances elsewhere?
So let's put this into context. From the period October to December last year, we were one of the best performers nationally in terms of our A&E performance. In January and February and the first part of March, every department in the country has been under enormous strain, and most trusts have been missing their performance targets, i.e. the 95% figure. We're no exception to that, but we're still in the pack. We're not one of the best performers, but we're certainly not one of the worst performers. We're about average in terms of how it's been going over the last few weeks. There's enormous pressure in the system, so we're seeing high numbers of volume in terms of people turning up at the A&E department. We're seeing quite a lot of poorly patients, particularly with respiratory problems and issues. There has been pressures nationally in terms of staffing of ED departments and acute medical wards. So there's lots of different issues in terms of both the number of patients, the acuity of patients, i.e. how poorly and sick patients are, and also staffing issues.
It is true that in the UK there's a national shortage of trained and available A&E staff, which is of course quite a specialist area. Why are we seeing a shortage of these particular staff, and is your A&E safe for patients?
So first and foremost, everything we do is to keep our department safe. So I can absolutely say our A&E department, our wards and departments are safe. We would not do anything else. But there is a national shortage of A&E doctors, A&E nurses. We have done lots of different things. So we've tried to employ different staffing rotas. We've tried to attract doctors and nurses from different locations. We're being innovative in terms of the way we staff our A&E department. So we have pharmacists, we have other consultants working in the ED department, but it is a constant pressure. So we do rotas well in advance for each individual day, and we're constantly having to review those rotas to make sure we have the appropriate level of staffing, both in terms of numbers and skills available.
I know we've spoken about this before in terms of people turning up at your A&E department, and there's never a time when those people wouldn't be seen. But surely it is right to say that there are times when people turn up. I hate using the word inappropriately because that's not the right word, but people turn up and shouldn't be turning up to A&E. They perhaps should be waiting till the following day to see maybe a chemist or their GP, or going to a minor injuries unit. How can we discourage those people from coming to A&E, which is, of course, nationally under a great strain?
Well, I think things such as this help us. I think it's about education. I think it's about continually trying to get the message over. And really, unless you need an ED department, they're not the right place to be. So, I always go through the escalator. Firstly think, well, can I self-care? If I can't self-care, could I go to a pharmacist? If I couldn't go to a pharmacist, could I go to a GP? If I couldn't go to a GP, could I go to an urgent care or walk-in centre? And only as a last resort would I consider going into a fully fledged ED department.
Kevin, we spoke at our last meeting about the fracture clinic again, and just to remind our listeners, this was around the transfer of fracture clinics from Blackburn to Burnley and the implications on that of the patients from the Burnley and wider Pendle areas. But we also chatted about the report from Healthwatch on your fracture clinic, and there seemed to be a mix-up about the fact that it could have been an orthopaedic clinic which was inspected and not a fracture clinic. Now, I've actually spoken to Healthwatch Lancashire, who say that it was driven by Healthwatch Blackburn. I haven't had a chance to talk to them, but are you able to throw any light on it at all?
Well, as I said previously, it wasn't our survey that was undertaken, but my clear understanding is that they visited the right clinics at the right time, and they spoke to patients and surveyed the right patients.
And we also mentioned in our last chat about you would review the situation regarding the fracture clinic following the board meeting. Have I got that right?
So what we'll have to do over the next couple of months, and it's going to take that period because we're going to have to do a full evaluation, is to gather all the evidence and then make a recommendation to our CCGs, our clinical commissioning groups, as to how we would like to go forward. And then we will come out with a joint proposal between ourselves and our CCG colleagues.
Staffing is an issue that you and I often talk about, and your trust, like all trusts, is struggling to recruit staff. Why do you personally think this is? And could you explain your decision to look to foreign workers to come in and fill your vacancies?
So if you think about workforce planning in the NHS, I mean, to take a medical student, and then train them right the way through, it can take up to between 10 to 15 years for them to become fully qualified accountants, and clearly a lot can change in that period. So workforce planning, certainly on the medical side, I'd say is more of an art than a science, and it has proved difficult. So on a national basis, there's some specialties where there's clearly a shortage. So A&E doctors, there are one or two areas where we've got an oversupply. So what we're trying to do is to make East Lancashire a really attractive place for people to come, and I think we're doing that. I mean, if you look at we were voted in the top 100 places last year to work in the NHS. We've just had the National Staff Satisfaction Survey and one of the top acute trusts in the country about what our staff are saying about their own hospitals. So I think we are changing the perception round that we are a great place to work. People will get supported. Yes, we are very, very, very busy. We know, I can't deny that. We have very, very busy services. So staff who come here need to be up for the challenge. But we are attracting some really good staff.
The BBC are reporting that thousands of nurses were refused permission to work in England, and that here at East Lancashire Hospitals Trust you have the highest number of refusals. They're quoting that 300 out of 300 applications were refused. Why are these applications being refused, and would you tell me that now you're at full nursing capacity? Have you got a full complement on your wards?
So we have full complements on the ward, but sometimes those complements are made up of agency or bank staff. We have historically gone out to recruit in terms of overseas, and we've got Spanish nurses working in our hospitals. We've got Filipino nurses, and during the last summer we did a big recruitment drive, and we offered posts to in excess of 80 Filipino nurses, and we're hopeful that they're going to be joining us over the next few months.
So there's no problem with their applications. This is something from last year.
So each one of them has to go through an individual visa application process. We're very hopeful that most of them will be approved and supported.
Now, it seems to many people that your trust often wastes time and money bringing people into the country, training these people, and then sort of 6 months or 12 months later these staff have moved on to other areas, like London, where perhaps salaries and work-life balance is said to be much better. I'd dispute that. How can you protect your investment in these people, and is your trust a good place to work?
So I don't think I would dispute the premise there that we waste money. I don't think we waste money at all. As I said to the previous question, we are one of the best places to work in the NHS now, and staff are saying that about us. If you think about it, we've historically gone out to recruit in Spain and the Filipinos, and we still have many of those nurses working with us. So generally our experience has been when we've gone for overseas recruitment, those staff want to stay and work within East Lancashire. And actually, if you look at London and the view that staff are attracted to London, actually if you look at the agency rate in London, it's far higher than in the northwest.
The government are imposing strict caps on the financial amount that trusts can pay for agency staff, and these caps are being implemented in stages. Are you still having to rely heavily on employing bank and agency staff to cover shifts? And subsequent to that question, isn't this going to create a huge problem in the future for trust and trusts? And what steps are you taking to ensure that staffing levels will always remain safe?
So everything we do, and we work day in, day out to make sure that staffing levels are safe in our wards and in our departments. The cap is having an effect, but I think it's the right thing to do. And what it's helping to do, I think, is to rebalance the workforce. So it's been very, very, very attractive for staff historically to work part-time, to go and work in agencies, and to pick and mix the shifts that they want. And if staff want to do that, that's the right thing to do. But I think there's been a too much of an incentive for them to do that, because the rates that the agencies have been able to charge have been very high. By now having a cap on those rates, I think what it's helping to do is to rebalance the situation, and more staff are coming onto our internal bank, or more staff are actually looking to want to work for us on permanent contracts. So I think over the period of time it's helping to rebalance the workforce, but it will cause problems in the short term.
Figures released today, on the very day that we're talking, show that there's been an alarming increase in the amount of attacks on North West ambulance staff. I'm sure the figures will then go on to show that there has been a subsequent increase in attacks, and we're talking not just verbal but physical attacks too, on all NHS staff. Is your trust one that suffers from this practice? It's absolutely disgusting that someone would want to do that, but have you seen an increase in that sort of behaviour?
I mean, we have a zero tolerance to any form of attack on staff, be it physical, be it verbal, be it emotional. The staff are working incredibly hard, doing really difficult jobs, and the last thing they want is to have any form of abuse. So we have an absolute zero tolerance. We do occasionally see incidents, and particularly at the very busy times, at the weekends, when we have people in who may be the worse for wear with alcohol, or in some cases even drugs. So it is something that we're aware of. We have a very good relationship with the police, and the police can be on site very, very quickly, or a lot of the time they're physically on site anyway. We have our own security staff, so we will deal with it very, very rigorously, and it will not be tolerated, any form of abuse of staff.
Well, that's good to hear, and I'd always like to think that your trust would be one of the trusts that follows up with prosecutions and takes these people to court.
Well, we have had instances of that. Even recently we've had instances where that's happened.
East Lancashire Hospitals Trust has always been seen as being innovative. I can see that from the 5 years that I've been involved locally in the healthcare sector, but I believe that your MSK service has recently won an award. Can you tell me more about that?
So that's the musculoskeletal services, and we work very, very closely with our local GPs and our local East Lancashire Clinical Commissioning Group, and there's been lots of people looking at how we can make that service better, how we can treat people outside of hospital, and it's having a real success. So by employing and working with multidisciplinary teams of hospital doctors and nurses, physiotherapists, occupational therapists, GPs and their staff, we're able to put a service on that firstly that supports people and keeps them out of hospital, and then when they want to, if they then need to come into hospital, we're able to discharge them quicker and support them more in their home setting. So it's a really good example of how East Lancashire and all the professionals in East Lancashire can work together.
There are a lot of hospital trusts sort of caring for people and offering more services for people in the community, which is actually what patients want, which is what patients are telling me. Do you think there'll come a time when East Lancashire Hospitals Trust is actually delivering services from GP surgeries, which a lot of hospital trusts seem to be getting into at the moment?
I mean, very much so. I mean, what we're looking to do, and we're working with our GPs, is to have multi-professional, call them neighbourhood teams, so teams that are based in neighbourhoods, based around clusters of GP practices, and you have all the professionals, so the doctors and nurses in the hospital reaching into the community settings, the GPs and their staff all working together with the hospital staff, and that is the right way, because you should only have to come into hospital if it's a last resort. If people can be treated better in a community or a GP or a home setting, that's absolutely what should happen.
There's recently been approval at board level for Phase 8 at the Burnley General Hospital, which of course is brilliant news. Can you tell us more about what that exactly will mean for patients?
I'm delighted with this. So this is going to be a significant investment over the next couple of years on the Burnley site. It's going to be in excess of 16 million of capital invested. It's going to allow us to knock down some of the old buildings that we've got and consolidate it in a brand new suite of buildings that's going to house a new outpatients department, a new ophthalmic department, a new dermatological and maxillofacial services. It's also going to allow us to tidy up the site and the access roads around and into the site. And it's going to, one of the things it's really going to do, it's going to link up a lot of different departments. It's going to allow us to have one main, I can put it called corridor spine, right the way through the hospital. Because one of the things I'm continually being told about the Burnley site is it is confusing for patients because it's been built up over many years and there's different phases. So this final phase will allow us to really tidy up a lot of the things that have gone on over the past few years, have a really clear hospital spine, one main corridor which all the wards and departments feed from.
We spoke at the last meeting about PLACE, which is the patient-led assessment of the care environment, which is actually due to take place here soon again for this year. Now, I'm always involved in those inspections, and I'm happy to report that you've recently acted upon one of those recommendations, which was to supply lockable lockers for patients' belongings at the bedside. It's in a trial, I understand, at the moment, but you've implemented that on a lot of wards. So congratulations on that. We should mention to patients that if they are coming into hospital, please don't bring your valuables in. But how have you managed to do that? Because it is it's a significant investment, first of all. And of course, the technology is new. So tell me a little bit more about it.
So I'm a great supporter of the place-based project because what it is, you get people who are very experienced, but also linking in with general members of the public, and they can come round and they can review what's going on in hospitals, how it takes place, and how things happen. And they pick up things that we do not see. So having those really acute eyes on what we do is really important, and we will pick up the recommendations from it. So yes, there is a cost and there's an investment, but it's the right thing to do because it was put back to us that this would be appropriate for patients and their belongings and for their safety of their goods, etc. And it was the right thing to do, so we've done it.
Kevin, you've recently had some more good news about the staff satisfaction survey. It's brilliant news, the numbers and figures are in.
No, that's absolutely right. So every year staff are surveyed, and this year over 2,500 of our 7,500 staff responded to the staff satisfaction survey. And it's really important because it's a great barometer of what your own staff are saying about the organisation. And I'm delighted to say that we were one of the top acute trusts, probably the third best acute trust in the country, in terms of what staff were saying about their own organisation. That, is it a good place to work? Is it a good place to have treatment? Do staff feel engaged and valued? And it's a real reflection of how good our staff are. And only last week, we saw that because the weather was awful, wasn't it? Some days last week when the weather was awful, and there were so many examples of staff, walking in, spending 2 or 3 hours just to get in, through that snow to make sure that they could deliver the treatment and care that our patients and our communities deserve. So I think we are really lucky. We have brilliant staff within East Lancs Hospitals Trust, and I'd just like to thank each and every one of them.
And on that note, I'd like to thank you, Kevin McGee, Chief Executive Officer at East Lancashire Hospitals Trust. Thanks for your time.
Thank you.
Remember that you can submit a question for me to put to the Chief Executive by contacting the email address below or by calling 01254 752 130. That's 01254 752 130. But please remember that the patient voice group is unable to enter into a discussion with the Trust about individual complaints. I'm Russ McLean, and wherever your journey of life takes you, have a safe trip.